So now it is my turn to show you BrosMed POT balloon for precision PCI in bifurcation lesions. So I will just work on cases. This is one case from a 71-year-old male with unstable angina. He had 3 vessel disease. We scored him with syntax 2 and we had AQ plus. PCI versus cabbage. He underwent a first rotablation procedure with 2 drug-eluting stents in the LAD, and this is the second procedure for RCA treatment. This is the RCA. I put a high support catheter because this was going to be a strong fight against calcium. The patient was quite obese, but I can highlight here 2 main areas of calcification. We went with a floppy rota wire and a front rota with a 1.5 millimeter bar. This was 3 runs at high speed and 1 run at low speed. I didn't want to go over the crux because I was not sure of the size of the PDA at that moment. But then after rota, it became evident that the vessel was actually good. And this was the OCT imaging with circumferential calcium and very deep calcium reaching 0.9 millimeters here, and also at the proximal part where the vessel is obviously larger. I pre-dilated a little bit with a regular balloon, 2.5 balloon, but shockwave 3.0 did not cross the distal bifurcation. So I used the balloon at the distal part and also at the proximal part, and I delivered the whole 80 cycles or pulses. And then I had this angiogram, which looks okay, but I was not sure on the distal bifurcation, so I worked on it a little bit more with a cutting balloon. This is a Wolverine 3.0. And when I was satisfied with the expansion, there's a bubble here, but the balloon actually expanded. I went with a 2.75 drug-eluting stent in a provisional stenting approach. You know, when you do a provisional stenting approach, you must do a systematic POT after implanting the stent, and then if you are doing a side branch intervention such as kissing balloon inflation or even a second stent implantation, you have to do a final POT or re-POT. So this is me using the BrosMed POT balloon. This is 3.5 and H balloon, and I'm actually working on the carina, as Gabor said. With this balloon, I really wanted to test if the shoulders were going to behave and stay within the limits. So I really pushed the balloon a little bit farther than where I normally do. And you can see here that actually the balloon is behaving very well, and it is almost a rectangle, which is really surprising to me. This is, for example, an image from another case, and you will see here very clearly the shoulder reaching at least 3 millimeters over the dots. And you see on the right hand this case where the POT balloon just stays within the markers. So you can really put your marker at the carina and the balloon will work perfectly. The problem with the left-handed cartoon is this one. If you go with your balloon and go over the carina, you will overstretch the distal main vessel. And a bigger problem is that you will produce a carina shift, so you will endanger your side branch here. And with this POT balloon, really you can stay within the area, and you will improve your scaffolding of the carina, and things will get very much easier if you want to recross here. This is an actual picture of the balloon after being used, so you really can see that the shoulders are really small, and this is even after using the balloon in the coronary. So the case goes on. I optimize also the proximal part of the stent. It is important to avoid the bottleneck deformation. So you have to ideally do the POT all the way back. And this was the angiogram after optimization. You really can see that the stent is very well expanded here, and the side branch is open with no compromise at all. I have some remaining. This is more proximal that I covered with the second stent, but the surprise came here. Probably this area had not been treated by shockwave, so it was a little bit unprepared, and I had this horrible under expansion here. So I used the balloon, the BrosMed balloon, also to post dilate this stent, and you can see that here it is 20 atmospheres. This is very high pressure, and the shoulders stays within range. This is the angiogram after second stent implantation and post dilatation. The case goes on for the proximal part, but I will skip that, and this is the final angiogram, and I wanted to show you the OCT images at the side branch, which is the PDA, and this is the worst area with the highest calcification, and you can see that the stent is very well expanded, and this is the other area where I misprepared the lesion, but the POT balloon managed to overexpand this stent to a very nice size of 3.4 millimeters. So this is my second case. This is an 84-year-old female with unstable angina, and the patient had a LED to diagonal 111 lesion, which was actually a little bit ambiguous. So we put a pressure wire down, and we did a non-hyperemic index DFR, which has the same cutoff for IFR, 0.89, and both branches were positive. This is the baseline anatomy. You can see that there is a true dual system with LED and diagonal. And actually, I had read Gabor your paper, so I said, why don't we do a DK-culotte here? And this was my imaging preparation for both vessels, because you can see that they are actually very, very small. So we have this proximal LED calcified area, but with very good lumen. This is the carina, which is actually free from bifurcation, mainly at the diagonal, and some calcification at the LED. This is the mid LED, which is actually a very small vessel. Lumen size is almost below 2.0, and the elastica doesn't get over 3. So this is a place where we couldn't fit a very big stent, and there was not a safe spot, so we had to land in plaque. And this is the diagonal, which is actually a little bit larger than the LED. So we pre-dilated with regular balloon. I believe this was an Alveo balloon, 2.0. Sorry, at the LED, at the bifurcation, then at the diagonal and at the bifurcation. And I put my first stent here. This is a 2.25, which I expanded at 20 atmospheres. I would rather pick a less large stent and then over expand it with high pressure later. And this is the landing zone at the LED, where you can see that it is actually a very small vessel here. The elastica at the distal part was 2.25. So this is the largest I could get. Then I did the POT. So this is the first POT for the DK-culotte or any other bifurcation. This is the most critical one. If you pick your POT balloon here, you will expand and facilitate the crossing to the bifurcation. This is a stent. This is a creditable stent which has a marker on the edges, so you can see here that actually the culotte is very short. This is 4 millimeters dual layer of stent here. And this was post-dilated with the POT, which reaches and goes over the edge of the stent, but doesn't get into the circumflex or the left main. So precision is very important here. I'm opening the carina. I don't want to get to the left main on the proximal side. This is the cartoon showing what I was doing with the balloon. And this is now a 0.25 stent, which actually reaches 3.5. And this is the IBUS showing that this is true. This is not my invention, and this is the distal IBUS. So as Gabor said in his presentation, you have to know your stent platform very well. Now you have the first kissing. You have to rewire the vessel. I did a kissing with 2 and 2.5 balloons, and then I put my my stent at the side branch. This is a guide wire on the circumflex, just as a marker, not to get into the left main. And you can see that this stent is longer, takes longer in the proximal LAD. This is the second pot, and you can see now with the wire in the circumflex why the precision is relevant. You want to go and open the carina very well, but you don't want to go and get to the circumflex or displace any carina into a circumflex. This is the balloon again. This is the shape of the stents. The first one is the red one, which is going shorter, and the second one is the orange one, which is going longer. And this is the rewiring. And this is how this balloon works. Here, if you go too distal, you might damage the proximal vessel in this case, or displace carina into a circumflex. If you go too proximal, you can have this bottleneck deformation. So choosing the right size of the balloon is important, and having virtually no shoulders is important. This would be the correct positioning. And actually, this is from Gabor's paper on DK-culotte. There are 3 pots in DK-culotte. This is the first one. This is the second one with both stents, and the third one will come after the second dual kissing inflation. This is the final kissing, and you can see very well the DK-culotte carina, which is actually very well formed. This is the proximal LAD with in the most proximal area with a single layer, and this would be the distal left main bifurcation with no metal at all, which was my target. Sorry, Gabor, I did not did the third pot because I actually saw in IBUS that this was very circular, so I'm very well expanded. So I finished my case here. This is some bench testing data on DK-culotte, which is, I believe, it's a nice technique when the distal vessels have a similar size, and actually it might behave better in terms of fluid dynamics compared to regular culotte and also to DK crush. And this is the final angiogram of the case, and this will be the scheme of the stents implanted. The strategy in my case was inverse, so my LAD stent would be the short one and my diagonal stent would be my long one, just because the diagonal was a little bit larger by IBUS. But I think this was a really good result for this old lady. She's doing well, at least for 4 months from the case right now. So this is my last slide. BrosMed POT PTCA balloon is the most precise balloon, and really it might be used in a lot of cases because bifurcation lesions are present in more than 25% of PCIs, and even when provisional stenting works in 90% of cases, you can see that some cases require two-stent strategy, and POT is mandatory in both strategies. POT is all about precision, and I think BrosMed POT balloon makes results predictable in terms of avoiding stent edge dissection or bottleneck deformation, and the balloon stays within inside even at highest pressures against severely calcified disease. So thank you very much. I will take your questions now. Gabor, Delio, feel free to ask also. Okay, so if there are no further questions from the audience or any of the speakers, yes?
Hello, Dr. Pablo. There's a question from the audience, and please wait for a moment. I will share on the chat bar.
Yes, please.
Okay, and a wonderful case sharing, and thank you for Dr. Pablo again.
Yeah, Pablo,
yes,
can you hear me?
Yes, very well.
Yeah, I want to underline in respect on your presentation that the POT technique, especially in all technique of bifurcation treatment, and we can see in your case also, it's very important for the correct position of the rewiring. So if you perform a culotte technique and you get in the wrong place or in the wrong strat with your wire, you can create a very impressive deformation of the carina and of the strat of the stent. So the POT, it's really mandatory when you treat the bifurcation with two technique, and in more complex is the bifurcation, more important is the POT technique, because you avoid to create deformation, important deformation of the strat, and to have a good result of the technique. So the rewiring,
I agree.
the rewiring in the correct position, especially in the culotte technique, it's very important. And the POT allow to make sure that you cross the strat in the correct position. When you cross.
Yes, I fully agree. So what happens if you do not do POT? If you do not do POT, you will have your vessel size like this, and your stent will be malapposed. So you can have the possibility of rewiring through the space between the stent and the vessel, and this would be catastrophic, because when you open the vessel, you will crash your stent. And so that is why POT is critical. And I believe that these two stent techniques are focusing on the two dual kissing movements, which is important, but most important, I would say that they are dual POT, dual kissing strategies, because dual POT is very important, and the first POT is the most important. Then it comes the second POT for the second rewiring.
I think that when every time you have to cross a stent or a strat of a stent, you have to perform the POT before this crossing.
Yes,
so
yes.
I think this is the
so
general.
Whenever you are going to kiss, please POT before. So POT, then kiss. So POT, rewiring, and kiss. That would be the sequence. Okay. There is one question from the audience. Dr. Pablo, thanks for sharing, and I have a question here. So, in which situation will you consider to use two-stent techniques in bifurcated lesions? So, generally, provisional stenting will go for maybe 90% of the cases as a philosophy. You start with that, and only if you lose the side branch, you will go for a two-stent. But in this case, for example, I picked a two-stent strategy because both branches were diseased, and there is usually a cutoff of 5 millimeters. So if the disease goes over 5 millimeters in both branches, it is a good idea to go for two-stent strategies. And the second situation is when the side branch is going to be very difficult to cross. Especially this works for very angulated circumflex so retro circumflex, for example, in the left main. Sometimes it would be very difficult to rewire in case you lose the side branch. So you might consider starting with a two-stent strategy. Maybe culotte or DK crash usually works better in the left main, but it depends on the situation. Thank you very much, Delio, and the audience for the questions. I've been told that we are above 300 people now connected to the webinar, and I will hand it to you, Delio, to give your presentation about provisional strategy. Please share your screen and get started.
Okay.